That's okay though. We can quickly go through our journal afterwards. SUBXIPHOID. So let's play through this video again. So again, this one's wrong because the probe marker is oriented to the patient's left. We want a probe marker oriented to the patient's right. But aside from that, it's a nice video just showing the structures we're looking at. Quick things to point out here. Obviously, this is one that can be uncomfortable. So if you can, do it last. But if you're really worried about the heart, do it first. Using the liver as a window is important here. If you've got stomach air and stuff, try to find a way to get the liver between you and the heart. Sometimes it can help to kind of blot the area a few times to move some of that air around if you're starting to get a poor window. And of course, keeping the probe really flat up against the patient's abdomen is important. So it's not a test where you're putting it in at a sort of perpendicular angle to the chest like you're doing for the IVC. This is something where you're really just right along the belly and basically pushing right down into the abdomen. Usually you don't want to have your hand underneath the probe in this case. Hold it from above. This is where you're going to see the fluid, of course, in the dependent area of the pericardium, and then the liver, it's pointed out there as well. This is a normal, so you'll see it play through here, and there's the different structures. So you've got your right side and your left side, of course, and I just quickly skipped through that apparently, but you guys have seen a lot of normals before. So the fluid here sitting in the most dependent area, which seems counterintuitive when you're looking at it, because it's like, oh, it's facing the probe, isn't it coming towards me? But don't think about that so much. Think about what the patient's doing when they're laying there and how the fluid is kind of sitting in a heart that's slightly tilted downwards. And so the fluid is going to sit more towards that distal end, that apical end of the heart, as opposed to something that's going to be further away from the probe. You typically will see it in this area, in between the liver and the heart, before you start seeing it behind the heart. Another positive here. Now this one's a bit more tricky. So because of some shadowing and artifact here, you actually don't see the free fluid as well. So it makes you think, oh, am I maybe just seeing some pericardial fat, which is a bit of a mimic, but it's pretty wide for that. I don't know why this one's not playing through. Actually, there's something in the way of the... There we go. But you can see that as it plays through, you are getting a clearer sense that there's some fluid there, and there probably is some fluid posteriorly here as well. This one, no doubter. Now this is playing through quite rapidly, and I don't think it shows up as well on the screen as it does on my computer, but and we'll talk about this at other times. You wonder about whether there is some collapse of some of the right-sided structures, which would be suggestive of a tamponade. It's not something that is strictly part of the FAST kind of test, so we'll talk about that at some other point. But this is obviously a kid that's got a lot of fluid around the heart. I should state that probably most of these images are not from trauma patients, of course, right? We haven't had many patients that have a lot of blood around their heart in a trauma scenario, but it's really kind of saying the same thing. In a true hemopericardial, fluid, you've got often clot mixed in there too. So keep in mind that it may not be this clear, hypoechoic stuff. There might be a mixed package of stuff in there as clot forms. This image I literally got off of Twitter this morning. Some top pitfalls when you're trying to assess for a pericardial effusion. Look for the descending aorta. And any pericardial effusion should be anterior to that. Pericardial fat is going to be this kind of more hypoechoic, but more hyperechoic than fluid kind of structure. This is one I can show you guys afterwards if you want, because the pictures aren't necessarily great projected here. The pericardial fluid, if it's going to run posterior to the heart, it should be above that aorta, as you can see here. So here's your aorta. Here's some fluid sitting above it. And then if it's a pleural effusion as opposed to a pericardial effusion, it's going to be behind the aorta, right? So in this case, you can see your aorta here, and then you see some fluid surrounding it there. So I thought this was kind of a nice image just to demonstrate some of the more subtle things that you can use to kind of gauge exactly where the fluid is. Key pearls, free fluid moves freely around in the abdomen, so just keep that in mind as the patient may be in a different position. FAST scans are not meant at any point to look for solid organ injury or hollow organ injury. The right upper quadrant for older kids, the left upper quadrant, sorry, I don't know why it said left upper quadrant, I meant pelvis there. That was my mistake, so that should say pelvis for younger child. Physiological fluid can be present, so context is important, right? So if you have a kid with a gastroenteritis who gets involved in a car crash, isn't complaining about a lot of belly pain, has a soft abdomen, and you look and you see some, free fluid there, context, right? So whether that's a kid that still needs to get a CT, that's a discussion, but keep in mind that fluid is not all blood. Obviously, you also want to modify the gain in the pelvis to improve your sensitivity. So drop the gain in order to see those small slivers of fluid. Quickly going through the evidence. In the adult world, the FAST is fully incorporated into ATLS. It's very used in any sort of adult trauma protocols. And the evidence is primarily sought to compare a FAST with the CT to look for those organ injuries. The most recent review does not look very favorably upon the FAST in terms of where it should fit into the trauma protocols, regardless of the fact that it's used. The Cochrane review from 2015 stresses that there's a big lack in the quality of evidence that's out there. FAST-based pathways have been shown, however, to reduce CTs. That doesn't mean that the FAST itself is inherently useful. It just means that when a physician has a negative FAST, they are cognitively unloaded and allowed to not CT as much, presumably. It's difficult to say for sure where the FAST fits into that, but presumably it plays some role in convincing you. There's no morbidity or mortality benefit or harm that's been shown from use of the FAST in the most recent studies. In 2009, the largest study that looked at the FAST in adults, it was shown to have a sensitivity of about 91% and a specificity of almost 99% for free fluid, and a sensitivity of 94% and a specificity of 98% in a need for going to the OR. Now, that's going to be better numbers than we'll see in any pediatrics. So just keep that in mind that that's adult numbers and not kids numbers. So what do we know in kids? Well, in 2014, that big PCARN database of trauma was sub-analyzed to look at FASTs. And so they looked at 6,000 patients with blunt abdominal trauma. In those patients, they found that only 13% of them actually had FASTs performed, and they found that in patients who were presumed to have a low pretest probability of having an abdominal injury, the FAST decreased the amount of CTs in those patients. So if you already thought this patient probably doesn't have something going on in their belly and you do a FAST and it's negative, it decreases your rate of doing CTs as a whole. Other than that, it didn't show any other inherent benefit or drawbacks to doing a FAST, including systems cost and otherwise. But it's one of those tests, it's one of those things which you can't use on an individual patient level. You can just say, on the whole, it seems that the use of the FAST is decreasing CTs slightly in a subsegment of patients. So that's really the take home there. But keep in mind that very few patients here, and probably center dependently, got FASTs. Many places in the United States don't do the FAST as a rule. The most recent papers, which I know you guys went over in Journal Club recently, this Holmes paper was a single center study. They had 925 patients. They randomized people to either having a trauma protocol that involved doing a FAST or one that didn't, but they didn't specify what to do with that information. So presumably you went up to a trauma came in and they said, this patient's getting a FAST, and they had to fast. It wasn't clear whether that mattered to whoever the physician that was doing the test or the TTL role at that time, like whether they were a believer, a non-believer, or someone who had no knowledge of the FAST, or someone who had intimate knowledge and was, an expert in it. And so in the end, they found that both groups had a similar CT rate, similar ED length of stay, and hospital charges were similar. It suffered from the classic lack of actual having that many patients that had injuries. I think there was something like 60 or 70 patients that actually ended up having any injuries whatsoever. And on the side of doing the FAST, there was some signs in the patients or in the physicians that there was some cognitive unloading, in the sense that those who were very unlikely to have intra-abdominal injuries, the physicians became more convinced that there was no intra-abdominal injury as a result of having a negative FAST. Interestingly, even in the group that the physicians thought had a less than 1% chance of having a intra-abdominal injury, 30% of them still got a CT. Pretty high numbers, probably not things that we would necessarily do here, and may reflect some institutional things, may reflect some of the changes in the way people manage things south of the border. And of course, the study design is complicated by the fact that the physician use of the FAST to help with the clinical decision is largely based on their own bias of the test, right? So if you're someone who thinks the FAST is the end-all and be-all, you are probably, in this case, going to be more likely to base your decision on it. Whereas if you're someone who doesn't use the FAST at all, even though the patient is now getting a FAST versus not getting one, it probably doesn't change anything about the way you manage them. So it wasn't clear that they used the FAST in a algorithmic way, right? So it wasn't to say that if it's positive, you're going to do this, if it's negative, you're going to do this. So I'm not quite sure what the point of randomizing them was to it if it wasn't going to be used in a particular fashion.